The topic that we're going to cover today, as you all know, is aesthetic implant failures, and particularly one of the topics that has been of interest to both of our groups for so many years is managing the two adjacent implants in the aesthetic zone. This has been a topic which has been a problem for probably people aware of it for over 20 years. And where are we today? What's the problem? Where can we go? So let's take a look at the outline that Steve and I'm with Steve Chu, of course, one of my partners and prosthodontist, and we're going to go through this area of the interdental papilla, and then we're going to go for probably about 45 minutes or so, and then David and Maurice will add another half hour or so on to show where they are, and then we'll have an open discussion between ourselves and with the people chatting in. So we look forward to the comments, and you can start, as things go on, you can type. We can see your questions. You can type them in. So we look forward to that. And so welcome all over the world. We look forward to the interchange. So let's get right to it. The interdental papilla, as you see, the outline for our discussion is going to be, first, is there a problem? Which now we do know that there is, of course, between two implants. Two, what causes the problem? Three, what is the solution? And four, can we repair the problem if it exists? We're going to take you through this. First, is there a problem? So let's take a look at this picture. This is what we see all the time. The sad part is that we see this more and more frequently than ever before. And most of this is because of lack of understanding of, it's not lack of understanding of integration. The problem is these two implants that somebody put in didn't integrate. They always say that you can always tell a badly placed implant always integrates for some reason. But this is a real problem because there's clearly a problem if you look at the interdental papilla area between the two, point to it maybe, between the two implants. The papilla is highly short. If you take a look at where it should be on the right screen, you can see that the papilla, let's go to the right screen, and you see the papilla is short compared to the natural papilla on the adjacent teeth. Now, why is that? What is it about the natural tooth that holds the papilla and that is not there between two implants? And we're going to come back to that in our discussion because we have to face that to see how do we avoid this problem and how can we fix it from ever happening, and if it does happen, then what do we have to do about it? Next, please.
Well, what's interesting is about the smile. The papilla is so important. It's such a small piece of tissue. However, in the smile, it really shows. So papilla displaced seems to be one of the biggest areas that we're really looking at. Now, if you look at a lot of the studies that are done prior, Tony Tejan did some studies at USC looking at 454 dental students, mostly young students between, say, the mid-20s to early 30s. And even though his paper was really focused on mid-facial tooth and or gingival display, he made a comment in his paper that of all the students he looked at, they all showed the interdental papilla, every single one of them. So 100% of the time, the papilla shows in the younger patient population. We know, based upon Vigen Brundo's work and David Sarver's work, that with increasing age, everything tends to go south a little bit. Meaning that with increasing age, the maxillary anterior teeth are less visible, and the lower anterior teeth become more visible. And you see it a lot of different patients with increasing age, they tend to show more of the lower teeth when they smile. Well, I had a very interesting conversation with Dennis and Mark Hockman, who's our orthodontist in our office, and we started to look at this and we said, well, if that is true, based upon what Vigen Brundo and Sarver says, is it true also in the older patient population, would their papilla show? So what we decided to do is we looked at 421 patients in our patient pool, and we looked from 3 different views. We looked at patients in their teens into their 80s, because that's roughly what our patient population is in our practice. And this is the frontal view that you would see, and you would probably say, well, this patient has a low smile, patients in the mid-60s. But if you look from the lateral views, the right frontal and left frontal view, you could clearly see that even the patient has a little bit of interdental recession, but the papilla is still visible. So don't get fooled that it's just the midfacial. It's really about the interdental. That's the most important piece to this. And a lot of patients will complain and say, well, how come my teeth don't look right? Shouldn't I be showing gums between my teeth? So on and so forth. Now, Dennis had suggested that we just look at a very simple question. And the question is it present or absent? It's just that simple. There's a lot of permutations associated with other things.
When the patient smiles.
Yes, when the patient smiles. But the key factor is it present or absent. You can see the breakdown by age. Patients in their 60s and their teens, it's way over 90%. But if you pool all the data together, the data clearly shows that it's not 100% of the time on the younger patient population, but it's 91% of the time. And therefore, it becomes a very critical parameter when we're talking about aesthetics, particularly pill aesthetics. So that's a very important piece, and we're in the process of finalizing this paper to try to get this information out, because people tend to only look at the midfacial because all the studies are done on midfacial. But we'd like to propose it to think differently, think about the interdental. That's very, very important. And that's what the discussion is about with two adjacent anterior implants.
That's great. Like you were to emphasize this, it's really a midfacial smile line and the interdental papilla smile line. We almost have to discuss both now.
Correct. And
obviously today we're talking about the papilla. And because of the scallop of this, let's say a central incisor, a typical central incisor, which we can come back to later during the presentation, a typical central incisor in terms of the scallop of the soft tissue is about 4.5 millimeters from the midfacial tissue to the papilla height. Now that's a long distance. So if somebody might not show the midfacial, you say, oh, like Steve just showed that case, oh, you know, this is no problem. We're fine. No, I don't see the gingiva margin. That you're staring right at the papilla, and that's obviously the black triangle has become a factor. So what causes this problem? So to go back just for a few minutes, we're going to go back just for a second to make sure we're all on the same page, to some of the research that both Garber and the Salamas, both of them, and ourselves have done over the years, and just quickly go over tooth to tooth. So we know what happens with that. Then we'll go quickly to tooth and implant, and then the topic of tonight, what about implant to implant, because that's really what we're trying to focus on. So let's go to the tooth to tooth first. And this is the classic. What happens is in the middle, you see there's a classic contact area is about 1.5 millimeters, 2 millimeters in diameter. And there's a normal coal that's present. Maybe you can point to that, Steve. There's a normal coal that's present over here. Buccal and lingual there. And there's a valley between the two. And the valley is non-keratinized. And that's what a normal papilla looks like. So when you see somebody smile, and they have a beautiful mouth and a beautiful smile, we just see the buccal piece. We don't see the lingual piece. And so then when you see, and if you look in a mirror, we see the lingual piece. So that's the normal healthy coal. Now, if you have the shape of the coal is determined by the shape of the contact area. And notice on the right, that what Steve's pointing, is that if you, and this is determined by us as restorative dentists, if you make a wide contact area, the shape of the coal is going to become wider, more hypertrophy, and greater non-keratinized area. Now, if you take the tooth out, which is what we're going to do when we do an implant, we have to lose a tooth, then go to the left side. Now the contact area is gone. And when the contact area is gone, notice that the papilla shrinks down. About how much? Shrinks down about 1.5 to 2 millimeters. Because that's what the coal is. The interdental coal is a hypertrophy of tissue. I'm going to come back to that because this is a critical piece for us to understand what we must get back, not just between a single tooth implant, but with two implants next to each other. In fact, this is really difficult for us to get back, as you'll see later. Next, please. And so what we did was we measured the base of the contact point to the crest of bone. And what you'll see is that we came up with the classic 5 millimeter rule that people talk about. And this article by myself, Magner, and Paul Fletcher has become a rather classic article. Next, please.
But even with attachment loss, that 5 millimeter rule stays constant.
It seems to stay pretty constant, but we just have to lower the contact point. And sometimes that creates a square tooth, and it doesn't have the beauty of aesthetics that the regular tooth had before. But you can close it down, as we do sometimes between two centers, which we'll talk about later.
They don't have the black triangle.
At least they don't have the black triangle, exactly. So this is the anatomy of the buccolingual dimension of a typical coal. And what you see where the red lines are is that's the hypertrophy. Everything above that is not attached. So there's no gingival fibers there. This is a hypertrophy that takes place. And that hypertrophy, when it comes up, is exactly what we're trying to regrow and is lost the moment you take the tooth out. And when does the papilla come back, like a single tooth? The papilla won't come back until you put a contact point back in, and that's for a single tooth implant. You'll see that if you put a flipper in, or don't put any temporary in, you'll see that the papilla will tend to come down and shrink. That'll be because we're going to lose that little piece of tissue, and it becomes a little keratinized little ridge. Then when you put the contact point back in with the temporary or the final crown, then it tries to hypertrophies up, and then the papilla closes up again. So we came up with that article in 1992, with a classic article about this distance. Next, please. And what you see is so critical that every millimeter of bone is critical. Because when you see 3, 4, and 5 on the bottom, you see that we wind up showing that we have almost 100% of the papilla filled up the space. This is between two teeth. And every millimeter is so critical, as we know, that when we go to even just 5 to 6, we lose 45% of the papilla, become black triangles. We go another millimeter, we lose another half of the distance, so another half of them. So we go from 50 some odd percent to 27%. And we lose another half of what we had, we go down to 10% with 8 millimeters. Look at that downward slope. That downward slope is so critical for us to look at, because every millimeter of interdental bone becomes critical. And we're going to come back to that when we talk about fixing the problems, that we don't want to violate the interdental papilla if it's there. And we'll talk about that as we proceed throughout the conference. What about tooth to an implant? So if we take a tooth out, we put an implant in. Uli Grunder and certainly the Garber and Salamer, we'll show you their data later. He looked at 10 cases. And what was interesting about this is that he found very cleanly, and this is Garber and Salamer did it as early as 1998, even before Uli did here, that the crest of the bone on the adjacent tooth was the critical area. That this bone right here was the critical area on both sides. What was interesting is the height of the implant was not critical. That was not critical as to whether or not the papilla came back. Now, we often hear about, maybe 4.2, 4.3 millimeters. But look at the average on the side. You see that the average is 4.2 millimeters in Uli's 10 cases. Well, what you have to look at, though, is that all of these papillae came back, but there was 5 millimeters or less. It wasn't just 4.2. In other words, if you get to 5 or less, it basically tends to come back just like in a tooth. And why does it come back? Because the height of the bone, where you see the probes, the height of the bone on the adjacent tooth will determine whether the papilla comes back. If that is 5 millimeters or less, average of 4.2, but if it's 5 or less, the papilla tends to come back, which is great news for us. So that's why everybody likes to show you single tooth implants. We'll show you single tooth implants all day. If the bone is good on the adjacent teeth, you're in great shape because you have all the attachment that you need. Next, please. So what about implant to implant? That brings us to the topic today. Now this was about 20 some odd years ago, 20 some odd, before Garber and Salamer did their work, before we had no idea of what we were doing. We just started doing implants next to each other. And here you see a central and lateral with the papilla is short. And now this case didn't come back to hurt me because this guy had a low smile. So I just had my technician 20 some odd years ago add a little more porcelain. We didn't even do pink so much then. And he just added a little more porcelain to close it down because he didn't show it. So this was my first wake-up call, but I didn't wake up. I didn't see the problem because it didn't come back to hurt me in any way. I didn't have to do anything to it other than add a little porcelain. I couldn't figure out why. Notice the papilla next to the teeth comes back on both sides. It's not bad. But notice the papilla between the two implants is short. And I didn't know why. I didn't even think about it at the time. To say, well, this is an oddball case. All right, let's just keep going. And like I said, I didn't get hurt by it. The guy accepted the case. He just didn't want the air escaping when he spoke. So we were okay. Esposito started to show us that there was a problem as far back as 1993. If you look at Esposito's work, you start to realize that he showed that the closer the implant was, where the yellow arrow is, to the adjacent tooth, the closer the implant was to the adjacent tooth, the more bone the adjacent tooth lost. In fact, if it was anything under 1.5 millimeters, he showed that the bone was starting to deteriorate radiographically on the adjacent tooth. And we just thought that was a surgical injury. We didn't even think about it. What you are really looking at here, this is without a platform switch, and we'll talk about that a little bit later. But without a platform switch, what we realized is that we always talked about bone loss vertically. And we talked about bone loss vertically, like up to the first thread, second thread, whatever. Then what we have to realize is that if we get bone loss vertically, we also have to have horizontal bone loss to the side. So we must get horizontal bone loss. You can't just have vertical bone loss without horizontal. The question is, how big is that horizontal space? And nobody really looked at that before. Thanks, please. In my article in 2000, it was the first time we realized that there was a horizontal component to the biologic width. That you lose bone vertically, you also have to lose bone horizontally. And our measurements were the following. Excuse me. That it was about 1.3 millimeters on a non-platform switch implant. That meant that we said, and we measured this peak of bone, and I figured that this was probably the reason that we had the problem of a short papilla. Because I said that these are close enough, under 3 millimeters, these two horizontal pieces would overlap, and they would do what? Knock down that bone, and therefore the papilla would be short. That was my original thought. So if you have two implants like you see on the left, it's greater than 3 millimeters apart. Once you attach the crowns and take them on and off a few times, what happens, just like Abramson showed in 1997, you start to see we lose bone down to about the first thread. That's about the 1.5 to 2 millimeters of biologic width. What we didn't look at the time was the horizontal distance. And this was the first paper that actually looked at that horizontal component. And that's why if the implants were greater than 3 millimeters, we tended to keep the bone. Now if the implants were closer than 3 millimeters, even though the bone is there when you put the healing abutments on, it disappears. Why? Because the two pieces overlap. The two horizontal components overlap, and you lose the bone vertically. So I said to everybody in the year 2000, listen, I got the answer. I was so proud of myself. Now everybody keep it 3 millimeters apart, and then we'll have a papilla between two implants. But I was still stupid, and the good news, everybody else was too, because I didn't feel terrible because nobody else got it either. So we kept it 3 millimeters apart, like you see in this clinical case. And Steve, what did you see?
Still have a short papilla.
Absolutely. We have a little scallop, so we got away with it, didn't we?
Sure. And in our study that we looked at the papilla scallop in reference to the tooth length, because we know that teeth can be various sizes, that it's roughly about 40% the length of the tooth.
The papilla length.
Yes, the
is about
papilla.
40% of the length of its central incisor.
Correct.
For most teeth.
Correct.
Right. And then we published that last year.
Yes.
So with Christian Stafford. So what you're looking at is a fake papilla. It's a pseudo papilla, and it's papillary illusion, as I and David sometimes call it, papillary illusion. It's not really a papilla because it's short. All you've done is increase the contact area and made the contact area longer so that there's no black triangle. But look at where the papilla height is. It's inefficient. It's insufficient. It's adequate for 2 centrals. We sometimes get away with it, but it's not perfect. Thanks. Now, what is the reason for this? So if we start taking a look at this, then ourselves, our group here in New York, and of course the Salama brothers and David and a few other officers, Dr. Cho, Frome, Magner, and ourselves, I said, let's look at the height of this tissue between any two implants, right, and from here to here. Now we didn't measure the contact point because of the fact that the contact point is arbitrary. The two crowns could be made any which way. I just wanted to see how much tissue there was from the crest up. Now David will show you with Maurice will show you that they did some of the first measurements down to the first thread, down to the bony contact over here. But we wanted to see that can vary depending upon the implant. So we then said, okay, let's just see how much tissue we have between any two implants that exist. And let's take a look at what we saw. And there you see the probe. Now, here's the problem. If you want to identify the problem, here you are. You're looking right at it. The average amount of tissue over the bone, an interdental bone, between two implants was only 3.4 millimeters. And in fact, over 50% were 3 and 2 millimeters. So over 50% of it was 3 and 2 millimeters. Over 50% were short. Instead of being about 5, we saw that they were short. 4 millimeters wasn't bad, 37%. But look at how few times we got to 5. Less than 10% of the time, 5.9, 0%, and 2%. We almost never got to 5 millimeters, which would be normal. 4 we might get away with it, but certainly 3 or less. Look at how many 2s there are, 17%, and 35% were 3s. This is why the papilla is short. About how far? About 2 millimeters, the 1.5 to 2 millimeters. We can't seem to get the cold back. We can't seem to get the papilla back, to the same height. So now we've identified the problem. The question is, why is it there? So you take a look at the average scallop that's present. Like as I said to you before, the average scallop is between the mid-height of the tissue of a central and the papilla height is 4.5 millimeters. Now the central incisor also has a scallop of the bone. The bone is about 3 millimeter scallop. Between 2 and 4 is average. And we've learned that from Ocean Beam and Olson and others. So what you see here is that, notice that the papilla is soft tissue, doesn't always follow the bone. In fact, you know, our colleague on the other side in Atlanta, David Garber, always says the bone sets the tone. I always love that. And in general, it does. But why does the bone not set the tone completely here? Why is it 4.5 millimeter scallop on the soft tissue and 3 millimeter scallop on the bone? The reason is the papilla is a hypertrophy if it forms. And it's that hypertrophy that comes up. And that hypertrophy is that extra 1.5 millimeters. There it is. And so if you take the tooth out, then the scallop of the tissue would be the scallop of the bone. But once the contact point's there and we get the hypertrophy of the papilla, we now see that it's 4.5 millimeters. So now let's put an implant into this equation. Whatever implant you want. We usually put it about 3 millimeters below the facial crest. And if we put it 3 millimeters below the facial crest, which is nice for nice aesthetics, nice running room, we create nice contour, what have we done? We then get a biologic width formation, and you start to see we have bone loss down to about the first thread on this implant. If we use a platform switch implant, it might only be like Prevail or Astra or LifeCore, then or Dentsply. What we see is it might only be 0.5 millimeter down. But normal one, typical, like the original Branamark implant, was about 1.5 millimeters. So look how far away the bone is on the implant. It's way up there where the arrow is. And from the contact point, it's 4.5 plus 3 is 7.5 plus another 1.5 to 2. You're almost 9 or 9.5 millimeters away at the contact point from the contact point. That's why Grunder and also David and Maurice and Henry showed very clearly that it is that the bone, the position of the implant vertically is not critical to the papilla formation. But look at the bone on the side. That's where it's all happening. That's the piece that is helping support this papilla and allowing it to come back. And here's the answer to the question. Why does this take place? Why do we have this problem? It's all about one thing and one thing only. It's not just the bone. Why is it that just keeping the implants 3 millimeters apart did not stop this problem from occurring? It was sitting in front of us, and we were looking at it. We didn't put it together. What it is, what does the tooth have that you see on? There's a middle implant here, and on the right side, the papilla comes back. On the other side, next to another implant, the papilla didn't come back. What does the tooth have that the implant on the other side doesn't have? It's not just the ligament. What it is, it's what's above the ligament, or coronal to the ligament. Where you see the green, but the red and the yellow is the gingival fibers and the epithelial attachment. And what you are looking at is supracrestal biologic width. And therein lies what we must focus on. This is the biology piece that if we don't get this, we'll never be good at getting this done. We must understand the problem before we can solve the problem. And here's the problem. So on the tooth, the good news is the papilla comes back, as you see here, because it has supracrestal gingival fibers, the tooth, if it's a healthy tooth, and it has supracrestal epithelial attachment. And that's on average 2 millimeters. So you already have 2 millimeters of attachment supracrestally, and then you get a normal 3 millimeter sulcus, 2.5, 3 millimeter sulcus, a pocket interdentally, and you have your 5 millimeter papilla. Let's take a look at the other side. You go to the other side, where's the biologic width on an implant? It's normally subcrestal, not supracrestal. So let's look at the difference between the two. Next, please. So we have subcrestal versus supracrestal. So what you're looking at here is, look at the difference of where the attachment is on the implant versus the tooth next to the implant. So it's supracrestal. And that gives us that extra support for the papilla, blood supply, and physical attachment. And what we're going to have to come up with in order to correct this is what? We're going to have something on the implant or the implant and abutment that is supracrestal also. If we're going to get a normal papilla between two implants, just keeping 3 millimeters apart, as you see in this diagram, is not going to be enough. Notice the bone level is the same on both. But what's missing? Supracrestal biologic width, supracrestal fibers and attachment. Got it. I say it again and again because we must focus on that. That's going to be the answer. So, can we repair the problem? What's the most obvious thing that we've been doing for years?
Just do Pontics.
Right, do ovate Pontics. And certainly the pioneer work by David Garber, Ed Rosenberg, and all the great Lenny Abrams, all the incredible work done at the University of Pennsylvania. And David was going to go through this in further details with some of the newer things that he's doing, including submerging roots under here. David's going to, and Maurice are going to go through that. And I think it's fascinating stuff that we have to put that into the equation as possible solutions for this problem. But ovate Pontics are great, and they'll go through their numbers later to show you what scallop they get and how much height of tissue they get compared to when a tooth comes out or two implants next to each other. So that's still a solution. We must never forget it.